Salam and peace be upon you. My name is Balkozar Adam. I work with the University of Missouri, Columbia. Today, I'm going to share with you how to use the practice parameter for culture competence in child and adolescent psychiatry practice with Muslim youth. I am delighted to be here and thank you for making the time to be with us today. I would like to start by sharing the story of Nadia. Nadia was a 10-year-old girl who lived at home with her parents and younger sister. They recently immigrated from the Middle East. She was diagnosed with cancer and she was struggling with depression. The pediatrician wanted a consult because her parents were hesitant to give her cancer medication. She was having difficulty accepting her illness. She threatened to jump from the hospital window and felt her medication were poisoning her. She had poor concentration, was irritable and angry. She has nightmares, decreased interest in playing video games, watching TV, or spending time with her friends. She said God hated her and her mother told her to repent. Her parents equated cancer with death. They believed that God would heal her even without medication. They never used the word cancer when they were talking to her or with the doctors. If the cancer medication bothered her, they told her she doesn't need to take it because God will cure her. They did not want her to be involved in psychiatric care, and she did not go to school for 1 month because she was not feeling good, although the doctor wanted her to go. As a psychiatrist, I recognize the stigma of mental illness, and especially in the Arab Muslim community. I emphasize confidentiality and acknowledge their fear of mental illness. The mother became more responsive. However, they continue to be resistant to medication. I emphasize biological aspect of depression, and it is not a personal shortcoming, and educated the patient and the parent about depression, and clarified the mother's thought process that not all cancer patients will die. I focused on how medication would increase symptom management, and they continue to resist treatment. I maintain communication with them and offer to see them on outpatient basis. After the symptoms increased, they agreed to start in SSRIs. She did better. Her cancer treatment continued. Her depression improved. She attended school. She met with the school counselor for support. What we learned from this case, we need to get family buy-in. That will help the patient take her medication. Father can play a gatekeeper role, so we need to get him to buy in. It's important to understand the place of the patient in the family and the level of the acculturation. Some Muslim family may prefer same-gender psychiatrists, which happened here. So do not underestimate the effect of stigma. Emphasize confidentiality, biological basis of mental illness, and that it can be successfully treated. Be aware of your biases. Take extra time. Dealing with this patient may be difficult because the patient may feel misunderstood by the society. Get support from school or Islamic center with the permission of the parents. So moving on, Muslim youth struggle bridging their identity with the American culture. As we know, Muslim youth struggle bridging their identity. The traditional Muslim values stress the importance of family, loyalty to parents, respect to elders and authority, religious adherence, and education. Adapting traditional and ethnic values to the American culture can cause dissonance. Now, I would like to move on to the practice parameter. This is a helpful tool when working with Muslim youth and families. There are 13 principles. The first principle, clinicians should identify and understand barriers that may prevent culturally diverse children and their families from obtaining mental health services. Studies show non-Hispanic white families are twice as likely to seek mental health treatment. Minority are less likely to continue outpatient or to use other treatment. Furthermore, minorities often wait to access medication and treatment. They have more issues with economic, geographic, and insurance. They are worried about stigma and double discrimination. They are not only minority, but also mentally ill. Many times, the troubling behavior is identified by the school and the courts, and not by the family. Principle 2, clinicians should conduct the evaluation in the language in which the child and the family are proficient. Psychiatry is language-based communication. Muslim immigrants who aren't fluent in English may not be able to fully participate. This brings the importance of translator and interpreter. If not, it may lead to misdiagnosis and adverse clinical outcome. Clinicians should understand the impact of dual language component on the child adaptation and functioning. 20% of American children 18 and under grow up exposed to two languages. English usually is their second language. If they have psychiatric disorder or learning disorder, this will affect their ability to learn the new language. This brings the importance of specialized assessment. A couple of things I would like to share with you. Sudden language immersion. When a child comes from overseas, a week later he is at school, he doesn't know what to say, so he doesn't talk. This needs to be distinguished from selective mutism. Another thing is maintaining the first or home language can unlock support and resources for the family and from the community. This practice was discouraged in the past, but we need to keep in mind that maybe the Muslim family are planning to go back to their country after they are done with their education, and maybe the Muslim parents does not speak English. Clinicians should be cognizant that cultural biases might interfere with their clinical judgment. Stereotype and prejudice both lead to unequal care. Oftentimes, these aren't blatant, but veiled or subconscious thoughts that creep into our action. Restoring to stereotype can lead to misdiagnosis and unequal care. A study done in 1999 asked 60 clinicians to evaluate Mr. X by reading a vignette. Keep in mind, his race was not given, but the vignette was written into two different ways. One in African American stereotype laden words, the other used more neutral words. Can you guess who was rated more negatively? Clinician rated Mr. X more negatively when the vignette was written in African American stereotype laden words. What this tells us is we are vulnerable to our own implicit biases. So we have to watch and be careful. Clinicians should apply knowledge of cultural difference in developmental progression, idiomatic expression of distress, and symptomatic presentation for different disorder to the clinical formulation and diagnosis. Culture differ in their motor, language, cognitive, and social development. If taken out of cultural context, it might lead to misdiagnosis and misidentification of pathology. In some Muslim culture, boys and girls do not leave their parents' home until they get married. So this not need to be distinguished for being dependent. Here we say, I was so embarrassed, I want to die. In other culture, they say, beating a dead person is a sin. Darb fil mayyit haram. The first one is not suicidal, and the second one is not a cruel person. If the patient is presenting with cultural syndrome, then you need to ask a colleague with cultural expertise to help you. Another example I would like to share with you is avoiding eye contact, speaking softly, declining to shake hands are signs of modesty in Muslim culture. This can be confused with depression and blunted affect. Clinicians should assess for a history of immigration-related losses or trauma, community trauma in the child and family, and address it in therapy. This is especially important in refugee population. Muslim families may have exposed to pre-immigration stress, including war, persecution, and economic hardship, or migration stress, including life-threatening events and physical harm, or post-migration, including poor living condition, social isolation, unemployment, and acculturation difficulties. In addition, they may face stress of prejudice and discrimination. The effect of stress on adults include domestic violence, criminal activity, family fragmentation. On children, it can lead to conduct disorder, aggression, sexual acting out, substance abuse, depression, and PTSD. Clinicians should evaluate and address in treatment the acculturation level, the presence of acculturation stress, and intergeneration acculturation family conflict. Muslim youth must learn to balance traditional culture at home with mainstream culture at school and outside community. The best outcome is bicultural identity, Muslim American, Arab American, Pakistani American. Other outcomes include marginalization, assimilation, separation, and negative identification. Therefore, it's important to address acculturation stress and intergeneration conflict in treatment. Clinicians should make special effort to include family members and key members of traditional and extended family in the treatment. So involving the extended family may be the only effective option for treatment to proceed forward. However, do not sacrifice confidentiality. Discuss boundaries and treatment parameters with the patient and the family. You need to obtain the help of a translator or interpreter in order to obtain valid consent form. Also, the family may need extra time because therapy and medication might be a foreign concept for them. Clinicians should evaluate and incorporate culture strengths in the treatment. When you are trying to understand the Muslim youth, it's important to be sincere when asking about cultural practices, values, and beliefs. Some families prefer a spiritual healer, an imam, a community leader, because of their non-clinical explanation, decreased stigma, and greater family support. So consider consulting them and including their input. Mutual respect and education of the spiritual healer will foster collaboration. Clinicians should treat culturally diverse children and their families in familiar setting within their community whenever possible. Most Muslim youth prefer ethnically specific community clinics or clinic within school and neighborhood. We have the Bridge program in Missouri where we see Muslim kids in school. Many of Muslim youth would rather receive treatment at home or community rather than hospitalization. In addition, children might benefit from getting support from the Islamic Center if possible. Clinicians should support parents to develop appropriate behavior management skill consonant with their cultural values and beliefs. Research revealed that culturally adaptive family intervention programs were superior to non-adapted version. Advise parents about parent practices that may be incongruent with Western culture, especially if it's against the law. Muslim youth may also get involved in arranged marriage. Clinicians should preferentially use evidence-based psychological and pharmacological intervention specific to the ethnic racial population of the child and the family they serve. Research disparity is noted related to minorities. There is overrepresentation of Euro-American and inadequate recruitment of minorities. During this conference, we will hear more about therapy approaches used with Muslim patients. I would like to bring to your attention the book Counseling Muslim, which I found to be useful when working with Muslim youth. The last principle is clinicians should identify ethnopharmacological factors that may influence the child's response to medication and their experience of side effects. We learn from studies of different diverse communities that we need to consider biological and genetic factors to combat health disparities. There are different patterns of medication metabolism and activity and risk of side effects in different populations. For example, African American and Caribbean Latinos with African heritage experience lesser response to SSRIs and more frequent extrapyramidal side effects with antipsychotic medication. Asian have a higher percentage of slow metabolizer, and they may experience Western medication as being too strong. Thank you for being here today, and I appreciate your time. Have a good day.